Hi, everybody. My apologies for not having these sessions for the last few days. A few unexpected things came up, but hopefully we'll get back into the rhythm of it from today. So what I wanted to discuss today was common CT findings in trauma that we normally see in the emergency department. Now, this particular session is really aimed at those of our juniors who maybe don't have much experience in radiology and in reading CTs, and especially those who may be working in rural and semi-rural areas, such as here in South Africa, where in our public health service, there's a great shortage of specialists, even though we may have, let's say people are not specialists, but to have a lot of experience in the different specialties, but they're not always available to us. And especially in things like radiology, most of the smaller hospitals don't have access to any sort of radiological services. Doctors interpret their own X-rays, CTs if available, and then you normally wait for reports until quite late, which is not something we can always do in the emergency department. And in the emergency department, we often find ourselves having to consult with juniors from the department who may also, for example, if you have a trauma CT, you may end up, discussing a patient with somebody from the surgical department who's actually junior to you, even though you're in the emergency department. And you may be the junior in that department as well, being now asked to look at CTs by somebody in the emergency department. So that's why I just wanted to, just bring out these common CT findings that a lot of people do. Um, a lot of things that we commonly do see in CT. And as for those who have joined live, as per usual, if you have any questions, you want to stop me at any point, you're more than welcome to. More than welcome to take any questions. Even you can use your mic or just on the chat or whatever it may be. And like I say, thanks so much for joining. So it's not that it's of no use to thanks. So it's not that this won't be of use to those who are a bit further along in their careers. We can always learn. But like I say, it's aimed more at those who really haven't had much experience and maybe asked to read or interpret CTs in situations where it is important that you have a quick answer and that you'll be able to differentiate a few things. So hopefully we'll be able to learn a few things from there. So for one or two people who did join late, like I say, if you have any questions along the way, feel more than happy just to stop me and just take it, just ask me any questions. So we're not going to concentrate on medical CTs. We're not looking at that. That I'll do in a separate section. I don't want to take up too much of your time on a weekday as well. So we're just going to talk about trauma specifically, what we find in trauma, and specifically CTs of the brain and of the head, which is what we need to look at, So that's the main thing, So it's to overview of intracranial hemorrhages that we commonly encounter in the emergency department. So today we're going to be looking at epidural, subdural, and subarachnoid hemorrhages. And this is often something I found amongst the junior doctors. An epidural gets called a subdural, gets called a subarachnoid. It's fine. It's easy to mix these things up, but it's good if you know the difference and you know why each one is the way that it is. So we're not really talking about stroke-related ischemia and hemorrhage, which, like I say, I'll cover in a separate presentation. Although if you follow this presentation, there's not much difference. The main difference being infarctions and bleeds into the brain itself. So let's have a look at an epidural hemorrhage. Okay, so now what I always like to tell people, because even before we read all of this and we go through that, the one thing that you'll notice about an epidural is that it has this, sort of like a roundish shape, if I can put it that way, what they call a convex shape. All right, like an eyeglass or or the outside of your eye. Now, for those who find it difficult to remember the difference between epidural and subdural hemorrhages, epi simply means outside. So it's outside of, the dura. So you remember that you've got your three layers of your meninges, all right? So you've got your dura mater, you've got your pia mater, and you've got your arachnoid mater that are all sitting over there. So your dura mater is extremely thick. If you did dissections in university, I know a lot of the universities have gone to digital dissections and very advanced stuff. But when I was at university, we cut up bodies. And the one thing I remembered about the dura was how tough it was. So what happens generally is that when a patient has an epidural hemorrhage, there's normally a bleed somewhere, between the dura and the what you call it, and the scalp. And this bleed has to slowly but surely move this tough dura mater away from the scalp. Okay. I can hear somebody. There is a question. I can start. It's no problem. Oh, I'm not sure. Somebody may have just had their microphone on by mistake. Okay, not a problem. But if you do have a question, just stop me. I'll happily answer. It's no problem. Or it might have just been somebody's.
Mistake. Was it you?
Okay, no, I think we're just hearing some background chatter on somebody's mic over there. But that's not a problem. The more the merrier. It sounds like somebody's mom in the back, but it's not. So like I say, you've got this tough dura mater that's normally attached to the skull, and then you have blood that starts accumulating, and it starts from a focal point, and then it slowly starts pushing the dura mater away from the skull, and that's what creates this. So generally, the apex of this, in other words, the furthest point is normally where the bleed originated. So most of the blood started collecting from here, and then it slowly but surely started making its way out. Now, it's not always the case. I'm just saying that's generally how it often occurs. So epidural hemorrhages generally occur outside of the dura. The dura itself is a limiting factor to the spread of the bleed. However, it can't contain bleeds. But epidural hemorrhages generally, you'll find that it takes them a much longer time to actually become extremely large, but they can become extremely large. So don't be fooled. But the best way to remember it is to think about, like I say, a bleed that starts off in one place and then is slowly pushing its way out so that it gives you this concave shape, or convex shape, depending on which way you look at it, all right? So as we can say, it's between the skull and the dura mater. It's often due to trauma. It's typically associated with skull fractures, although not always. Like in this case, if we had the full CT, we may be able to see that there was something there. Biconvex or lens shape. So they're talking about this shape here, right? So it's a lens shape. It doesn't cross the suture lines, which is quite important. That is quite true. It doesn't cross that. And it often compresses the adjacent brain tissue as well. So what is the clinical presentation? It's a lucid interval followed by a rapid deterioration. So the question may be why? So what happens is the exact same reason like what I had said, where that it takes a lot of force initially for it to push this dura away. And as it's pushing the dura, as it's moving it away, it actually becomes easier and easier for it to actually exert what we call a mass effect onto the brain. So you'll often find patients are okay, and then their GCSs just start dropping. But your patient will often have other signs. It depends on how big the bleed is as well, and whether the bleed is self-contained or not. So the most important thing to just remember is that this shape, this biconvex shape, or even this concave shape, if you want to call it that, that's generally what we call an epidural. So outside of the dura, that's where the hemorrhage is occurring. I hope everybody understands that before we move on to the next part of it. If you have any questions, more than welcome to go back and we can explain it again. But epidural and subdural. Once you've seen the two, it's quite easy to distinguish between them. And this is one of the most common ones that you'll see in trauma departments as well, because it is so commonly associated with trauma. Okay, so what we're going to do now is we're also going to answer a question that often comes up with people, is that how do I know when something is chronic as compared to when something is acute? Because very often, even us as seniors, we often get CT scans sent to us, and the person says, this person has a bleed, there's something very, and when we look at it, we can say, but this looks chronic. And, I do feel sorry for the juniors sometimes, because we don't often teach you the difference between, what's an acute and a chronic. So hopefully you'll be able to pick it up here. And what applies for the acute epidural and chronic epidural sort of applies for all of them. And we're going to have a look at the two. And once you see the difference between the two, you'll be able to immediately make out the difference between them. So the acute epidural hemorrhage is hyperdense or bright on CT, and the chronic tends to be hypodense or darker due to clot breakdown. And with your acute epidurals, you have clear demarcation from the adjacent brain tissue, but in resolving or a chronic epidural, you'll have a mixed density appearance. So let's have a look and see what that looks like. So here we have an acute, and here we have a chronic. And here you can immediately see the difference between the two. So an acute, as we said, nice and bright, whereas a chronic tends to be a little bit darker. Now, it depends on the chronicity as well. I'm not going to get into that because there are ways to actually tell how chronic a chronic epidural is, but that's not important for you at this stage. The important thing is to know that once you see a bright epidural or a bright bleed, you know that this is an acute bleed. And once you start seeing a darker bleed, that's when it tends to be more chronic. Now, the other thing that they had mentioned is that it's quite easy to demarcate it from its surrounding tissue. And as it becomes, well, this one here is technically not a very chronic one, but you can sort of differentiate it. But you can see in certain areas, it's not as easy to differentiate it from the surrounding tissue. So those are the two main markers that you would look at. Now, there's also edema. There's a few other things as well. And by no means at the end of this presentation are you going to be an expert on the CT scans. Please don't go and sit in your radiology department and say, listen, I'm reporting on everything. All of you can go home. No, no, no. That's not the point of this. The point of this is just to give you the very, very basics so that you understand. So I hope you guys understand the difference between the two now, and you understand what an epidural looks like. And you can see the chronic epidural also has that classic shape. You know, it has a biconvex or concave. If you're looking at it from this point of view, you can see again, it generally has a large, and then, you know, as it's been pushing the dura away, it becomes smaller and tapers away towards the edges. So that's how you can see what's going on, you know. So I hope that makes sense, and I hope you guys understand that part of it. And like I say, if you want to go back, more than welcome. Just stop me in the chat or on the audio, and then we can take it further. So this is another one that often trips up people, and this is now the subdural hemorrhage. So again, let's just look at what that means. So subdural means below the dura. So again, if you look at your layers, dura mater, pia mater, and arachnoid mater. So subdural hemorrhages generally occur, excuse me, just below the dura and above the arachnoid, the pia mater, sorry. So what happens is that because it's below the dura, you've got this tense dura that's sitting on that side, all right, still attached firmly to the skull. But you have this much more pliable pia and arachnoid mater that are now just sitting against the brain, all right? And if you've seen that, it's actually quite friable tissue. It's not exactly tough. It's not meant to, you know, provide a lot of protection for the brain. It's almost like fascial tissue, if I can put it that way. So what it means is that as soon as the bleed occurs, there's nothing to stop the blood from spreading except for a nice squishy brain. And that squishy brain is very easy to push out of the way. So what happens is that the blood just starts spreading, and it just starts pushing the brain out of the way. So it has this very typical pancake or crescent shape, depending on who you listen to. A lot of them call it a pancake shape. Some people do call it a crescent shape as well. So I hope that you can easily tell the difference between an epidural and a subdural. All right, so let's just annotate the two here just so that we can, I just want to see if I've got a nice color. So, you know, hopefully, you know, we won't kill this patient by doing this, but so an epidural would have that appearance, okay? So you've got that biconvex shape, you've got an acute bright bleed, and your subdural, on the other hand, would have this pancake or crescent shape that now appears because all that it's got that's blocking it is the squishy brain tissue that's in front of it. So what this means is that it has the potential to actually spread very quickly. Because there's really nothing to stop the progress of the bleeding. So with an epidural, the dura mater can sort of tamponade the bleeding to a certain extent, not always, and not to say it's a complete tamponade, but it can to a certain extent. But now the brain tissue itself cannot provide any protection. It cannot provide any resistance against this blood that's collecting over there. So all that happens is that the brain starts to move out of the way. And as the brain moves out of the way, eventually the brain will get pushed into the spinal cord. And I'm sure you have all heard the term coning. So that's when coning will happen and your midbrain gets pushed down into your foramen magnum and your patient, well, demises, unfortunately. Now, these are things that you need to suspect as soon as your patient has signs of neurological injury. They are presenting with their signs of neurological deficit and things like that. Okay. Okay. I think I'm not sure if there's a question or if it's just somebody's speaker. Okay, I think it's just somebody's speaker in the background. I think it'll be easier to ask questions on the chat because sometimes we can't hear the audio too well. Or alternatively, if you can put up your hand and then I can stop and listen to your audio question as well. It's not a problem. Okay. So the location is between the dura mater and the arachnoid mater, and the cause is commonly due to head trauma, especially in elderly and alcoholics, and imaging characteristics, crescent shapes. I think just
Yeah.
sorry. Sorry about the Dr. Chuch. Is it Dr. Chocho? I'm not sure. I think we were just getting a bit of background feed from your mic, so I apologize for that. I just had to mute you. So apologies for that. You're more than welcome to unmute if you've got something to ask, but it was just feeding through. So my apologies for that. I'm not trying to be rude or anything like that. Okay. So it does cross the suture lines, but it's limited by the dural reflections. All right. So that means where the dura itself impregnates it, invaginates into the brain tissue, it won't cross across that. Okay. And it can cause significant midline shift and brain compression for the reasons that I had mentioned, which is that the brain, soft, squishy brain is getting moved out of the way. So clinical presentation, gradual onset of symptoms. It may mimic a stroke in some cases. In other words, your patient should have neurological deficits, not necessarily, but it is quite common. Any trauma patient that comes in, I suppose the question that needs to be asked next is, okay, how do I decide to do these CT scans? And there's quite a few videos that I've got on that, on how to do a neurological examination. I would suggest that you go back and have a look at that. But the main thing is, does your patient have neurological deficit? First thing, your GCS, your pupils. Then you need to go and have a look at the patient's power, their tone, all the simple things that we learned in medical school. There's no rocket science to it. There's nothing special that's going to tell you I need to do a CT scan. If your patient has neurological deficit in the setting of trauma, that patient deserves a CT scan. All right. Now, of course, there are sometimes, I wouldn't say exceptions, but there are times when you will need to look at a patient who's maybe fully conscious, but still decide to do it. So that may be, for instance, somebody who's got signs of a base of skull fracture, a patient who's got facial fractures, a patient who's got certain sinus fractures, things like that. So they are. So here we look again at an acute versus a chronic subdural hemorrhage. So again, we can see the brightness of an acute bleed versus the hypodense nature of a chronic bleed. And we can see the easy demarcation again of the acute bleed versus the chronic bleed as well. I'm not sure if I see one of the participants. I'm not sure if it's Dr. Moses who's joined us. She did a lot of time in radiology. So if that is you, Dr. Moses, you can just say hi. And if you want to pop in at any point and give us any pointers, I don't mind, but it may be I saw the wrong person as well. So if it's not, sorry if I mentioned that. But anyway, yeah, so those are the two things that you need to look at. So the last one that we're going to have a look at is, oh, it is you, Chanel. Okay, that's good. So all the way from Ireland, Dr. Chanel Moses. She worked with us in the emergency department for a long time and then went across to radiology. And she actually did CT scans to a much greater extent. So I think she's just popping in just to see how bad I am at CT scans. Rather than actually learn anything, because she was the person we would ask about CT scans. Hi, Chanel. I hope you're well. I hope the family is all okay. I hope they're all doing okay. And I'll just so that she doesn't embarrass me too much, I'll just say what I said at the start. This is just an introduction for juniors on how to read CT scans in the emergency department. But Dr. Moses, you're more than welcome to give us any sort of advice or anything. And if you want to say anything, just put it on the chat and I'll just keep quiet and you can just tell us whatever else you would like to know. So I just wanted to show the guys as well, so show everybody a subarachnoid hemorrhage. So subarachnoid hemorrhages do occur. They occur within the subarachnoid space, and they tend to follow the brain contours, all right? So there's two primary reasons. One is a ruptured aneurysm, and the other one is trauma. Now, the reason I'm not concentrating too much on where you would see these is because there are different types of subarachnoids that you get. But generally, what you would see is that you would see a hyperdensity in the basal cisterns, the sulci, and within the fissures as well. So there's the fissures over there, and there you can see the blood in the cisterns as well. And then the star sign can be seen in severe cases, but I'll show you that on another slide. And that's blood pooling within the basal cisterns. All right. So what is the clinical presentation? A sudden severe headache, or what they call a thunderclap headache, followed by nausea and photophobia. Now, in the setting of trauma, what this patient looks like is a patient who's presenting with signs of meningitis. But this is in the setting of trauma. So your patient has had some sort of trauma, but the patient is nevertheless complaining of a severe headache. Subarachnoids are graded as well, so they can present with mild headaches. They can go up to very severe headaches. They can be completely comatose, can be completely wide awake. So that's not the differentiating factor. What really sets it apart is that the patient has signs of, let's say, what we would call neck stiffness, fasciculations of the neck muscle. So that would lead you to suspect that this patient may have a subarachnoid in the setting of trauma. Outside the setting of trauma, you have a patient who comes in, maybe is a bit drowsy, has had a severe headache. We've got a whole presentation on that you guys can have a look at as well. So you attempt to do a lumbar puncture, and it looks traumatic because there's blood that's coming out, or you get yellow tainted blood, which is xanthochromia. All right, that's something else. So that's outside of that. But generally, subarachnoid hemorrhages we do see in trauma, but epidurals and subdurals are the more common type that we would see as well. Sorry. Just take it on from there. So this is the star sign in subarachnoid hemorrhages. So it's this starfish appearance on CT due to large amounts of blood, in the areas of the basal cisterns and surrounding the circle of Willis as well. So this is quite an ominous sign. If you do see it, you should not see this. All right. So that's one of the things that you need to look out for. So, sorry, let me just hide this. I didn't realize the slide had gotten so big. So we're just going to have a look at midline shift, all right? Because this is one of the other things I often find people having a bit of a problem with. So what is midline shift? Midline shift is basically telling us the middle of the brain, all right? Basically where the ventricles would meet, where we would normally see everything in the center. How far has that moved away from the center? That's all that midline shift is. Now, there's a particular way to work it out, which we'll go through here, but that's all that it is. And the worse the midline shift, the quicker your patient needs, surgical intervention, the quicker they may need, something to relieve the pressure that's going on over there. So it's displacement of brain structures from the center due to increased intracranial pressure. It's mass effect from hemorrhages, tumor, abscesses, or brain swelling. So on the CT, it's the shift of the midline structure. So it's the septum pellucidum, which is here between the ventricles that you can see over there. And it's normally measured in millimeters, from the actual midline, all right? So what's the importance of knowing it is that it indicates the increase in intracranial pressure and the greater the potential for herniation, as we had mentioned before, all right? So it requires urgent assessment and not possible, but you should be escalating it if you are working in an emergency department. And generally, a shift greater than 5 millimeters is considered significant and often indicates a severe mass effect. So for a lot of people, they often wonder, how do we work this out? And it's actually very simple. It's not difficult at all. Actually, just want to try and get a straight line here just so that I can draw that properly. So if we take this as the expected midline, all right? So let's just say that's where we expect the midline to be. Then we draw a line through where the new midline is. So in other words, where the septum pellucidum is now actually running, okay? So it's running more or less like that. And then we measured the distance of a perpendicular line from that to that. So this is not 100%. You'd sort of measure it like that. Okay. I hope I've got that right, Shina. If I've got it wrong, more than welcome to correct me. I don't mind. It's really not a problem because you would have done this a lot more than I would have. But that's basically how you work it out. And then you measure that in millimeters. And as I was saying at the start, because many of us are working in areas where we don't have, radiological services, and we don't have, we don't have people to advise us. This is an important skill to know. So you can eyeball it as well. You can also work it out if it's extremely small. But if it is extremely large, you know that you need to escalate this and take it up further. Okay. All right. So I hope everything I've said so far makes sense. I know I have a habit of speaking a bit fast and sometimes just slurring a little bit. So if that's been the case, and if there's been anything that hasn't made any sense, now's the time to just stop me and just ask, and can always go back and review and things like that. Okay. Let me just get on to the next slide. There's not much more to go. So what is mass effect? It's a very simple thing. You will hear the term being thrown around a lot when it comes to CTs of the brain. So it's displacement or compression of brain structures by an expanding lesion or expanding hemorrhage, like we say, hemorrhage, tumors, abscesses, or edema. So what are the CT features? Ventricular compression or distortion, effacement of the sulci and cisterns, and midline shift, which you can see quite easily in this one, for example. You can see how everything's just been moved, and there's quite a significant mass effect that's taking place over there. Of course, it implies increased intracranial pressure, and the worse the mass effect, the greater the risk of herniation and neurological decline. Management, urgent evaluation, ICP reduction. Sometimes you may be working in an area where you don't have access to immediate CTs. I don't know if anybody would be able to tell me, how would you figure out raised ICP without having a CT scan? I mean, you've got a patient maybe who's lying over there, you're working in, somewhere in a remote area, and you really don't have access to a CT scan. How would you be able to say it? So there's a few ways that you can tell. One is you can use an ECG. It does have particular signs that you can say. I've actually seen one earlier today from our emergency department, but that's a whole other topic on its own. The easiest way to have a look at it is that you'll have quite a simple so you have quite a simple way of telling it. Your patient becomes bradypneic, bradycardic, and their blood pressure starts to go up. So those are the three signs that you look for. So the breathing rate slows down, the heart rate slows down, but the blood pressure starts to increase as well. And those are the things that you would look for. And hopefully, if you guys have a chance, it's quite a long lecture. It's about half an hour, but it is on the playlist, if I remember correctly, where we talk about ICP and the ECG as well, and how to look for it. So let's just have a quick recap before we finish. So epidural outside the dura generally makes this lens shape, all right? It generally starts with the patient being okay and then getting worse, although they can come in bad already. The way that you tell acute from chronic is quite easy. Acute bleeds tend to be brighter. Chronic bleeds tend to be darker. Acute bleeds are much easier to make out from the surrounding tissue. The longer the bleed is there, the more difficult it is to make it out from the surrounding tissue. A subdural hemorrhage is between the dura and the rest of the brain. So there's only a squishy brain in between the bleed and basically the brain is there. There's nothing to stop the blood. So the blood just starts collecting and it creates this pancake or crescent shape that occurs there. And these patients will present similar to a stroke, but these patients can also present with acute severe neurological deficits as well. And it's quite easy now to make out an acute from a chronic as well. Like I say, we're not trying to become masters of the CT scan. I will do more CT scan lectures as the days go on, or as the weeks go on. But for now, as an intro, this should at least give you an idea of how it looks. Subarachnoid hemorrhages, got a presentation where I've delved into this into much greater detail. But for right now, this is what you should know, what a central subarachnoid hemorrhage looks like. You can have diffuse and you can have, there's one more, just slipped out of my head. But those, and then the thing to look out for is the starfish sign, which shows you that there's quite a bit of blood that's actually collected in the brain as well. So before any of you start feeling like, okay, you know what, I need to know the brain inside out before I can start commenting on CTs and things like that. As you can see in trauma, it's quite easy to actually just go ahead and make a quick assessment based on what you can see. Even amongst radiologists, you have neuroradiologists, you have people who specialize just in the brain and looking at imaging of the brain, simply because there's so many things that can be found. So you're not, like I say, there's no way you're an expert at the end of this little chat that we've had. But I hope that you'll at least understand the basics of what to look for in an acute trauma CT. So again, you know, you can work out your midline shift if you need to. It's quite easy, as we had explained. Pick the central point, look for the septum pellucidum, which is between the ventricles over there, and then just draw a line through there and then measure the distance between that. But generally, you can eyeball it. And if it's more than 5 millimeters, that's when you know that it's quite bad. Mass effect is what we expect to happen after hemorrhage. And what we're trying to prevent is we're trying to prevent that midbrain from going through the foramen magnum at the top of the spine and your patient dying, all right? And these were just some other ones that I wanted to show you guys just so that you'll know what it looks like. This one here is an intracerebral bleed, all right? So that's when you have bleeding within the cerebral tissue itself. Here are some contusions that we can see over there. And these are what skull fractures look like, you know, and once you've reconstructed, it's quite easy to see skull fractures as well. So these are some of the other things that you may see. And this is a pneumocephalus. So pneumocephalus, of course, is air within the intracranial cavity, which is something else that you can see. And you can see air has a completely different look to blood, you know, so it's quite easy to make out a pneumocephalus, and it's something that you may see from time to time. So an intracerebral bleed, contusions, skull fractures, and a pneumocephalus. So these are some of the other things that you may see. All right. So common pitfalls. It's easy to miss small hemorrhages, especially if you're not used to looking at them. So the best way is to practice by looking at them. A lot of people do confuse the acute with chronic bleeds, but I hope none of you will do that now. You shouldn't ignore the midline shift. It's imperative that you do look at it when it's there. You must look at the bone windows as well, you know, to make sure that there aren't any fractures and things like that, to the best of your ability. You may not, for instance, be able to pick up a base of skull fracture. That's very subtle. Even radiologists do struggle with that sometimes. But, you know, it's something that at least you should be able to pick up a facial fracture. You should be able to pick up a skull fracture at least, all right? So you're neglecting the sulci and the cisterns, looking for swelling, mass effect, things like that. Mistaking normal variants for pathology. This often happens. And this is not something that you can really get away from. All of us tend to sometimes look at things and they look abnormal to us, but they're actually normal. So the only way to get to that stage is to look at a lot of normal CTs and understand normal variations and hopefully get to that point. But most of us, it takes quite a few years of looking at it to actually get to that point. Then one of the things that can happen in any part of medicine is focusing on obvious findings, and you miss other things. So you would, for example, maybe just look at the epidural and forget a fracture and see miss another contusion or something like that, you know. And then, of course, you must correlate it to the clinical context. So, you know, is the patient a victim of trauma or not? You know, does the patient have high BPs? You know, there's a lot of things that you need to look at. You can't just ignore the history of the patient. And skipping follow-up imaging, although it doesn't really affect us as much in the emergency department, if you are working in the ICU or in a high care unit, this may be something that you need to look at. That if I didn't see anything on the first run, doesn't mean that there's nothing there. You may need to rescan a patient. It may need to be done quite soon, or sometimes a few days later. And if you are not sure, escalate it to somebody within your hospital, within your department, to somebody at a referral center, but escalate it. If you feel there's something wrong, The worst that will happen is somebody will laugh at you and say, why did you bother me with this? But at least you've satisfied yourself. And you can always write down who you spoke to. And if something goes wrong, you can always point the finger at them. So that's the best part of that. But, generally, don't take it completely upon yourself, especially if you're a junior doctor looking at CTs to say, I'm going to answer all of the questions. Don't do that. If something doesn't look right, just make sure that you ask somebody. And that applies to anything, any X-ray, ECG, blood results, anything. If you're not sure, ask. And if need be, especially in these cases, escalate as quickly as possible. So the key points: identify things quickly, recognize when you need a CT, and make sure that you do it. Understand your, all right, well, density changes, so correlation with the time since injury is one of those things that you need to know, and consultation and escalation. So if you do find something, don't just be happy that you found it. Make sure you involve somebody who can do something about it, be it a neurosurgeon, be it a general surgeon, trauma department, somebody who can actually take it further and help to save the patient's life, hopefully. Okay. So that's just a joke just to finish off. So how a CAT scan really works. So I'm not sure if anybody has any questions. We still have a few minutes left. I want to thank everybody for joining. It's really nice to have all of you on. And I hope things made sense. And like I say, if there's anything that you just want to go through again, we can always go through it. Like I say, I will have another talk on medical, medical causes of bleeds and things that we see from the medical point of view, if I can put it that way, not necessarily related to trauma. But in the emergency department, I would say 60 to 70% of your CTs are going to be trauma related, and then the rest are going to be medically related and things like that. Of course, depending on where you work and the situations that you find yourself in. Most important thing is familiarize yourself with normal CTs, then it becomes very easy to pick out abnormalities. And if you're not sure, even if you go tomorrow and you can't remember what an epidural or a subdural or a subarachnoid is, but just the fact that you can recognize something is wrong, ask. It means that you will learn. If you don't ask, you won't learn. And that's the most important thing that I can teach you guys, is always escalate if you are not sure. The worst that can happen is that somebody laughs at you and asks, why did you ask about this? You should know this. That's the worst that can happen. You feel a bit small for a few minutes, but at least you know you've tried your best. And that's the most important thing. So, yeah. Shana, I don't know if you're still there on the chat, or if you are still there. I'm not sure if you have anything to add, because you did radiology for a long time. I'm not sure if you'll do X-rays in Ireland now. But if you'll do, I'm not sure if you have anything that you want to add, or just tell our junior doctors about, or just give them any advice. Got about 3 minutes left before the session ends. And if not, that's fine as well. Okay, not really. Okay, no problem. But okay, I guess that means, as having moved to Ireland now, you've completely forgotten everything that happened the 2 years of radiology. No, but it's fine. No, I'm just kidding. I'm just joking. But no, I just hope everybody enjoyed it, and I hope everybody learned a little bit of how to just be able to look at a CT scan and understand how it works, and just the basics of what we are looking at. Okay. No, thanks a lot. I appreciate that. And yeah, if there's no questions or anything like that, hopefully on the weekend, I'd like to tackle another topic. Got quite a few lined up. So probably go through an ECG or blood gas analysis that I was looking to look at as well. But there are a few things that I would like to show you guys. So until then, thanks so much. I really appreciate it, to all of you. I know a few of you have joined from overseas, and I really, really do appreciate that. And to those who have joined us from overseas, no, thanks. I appreciate that sentiment as well. To those of you who joined us from overseas, I know you must be looking at us and wondering what we're talking about, because I know in some of the countries you guys have a CT scan like next to every bed, and an MRI around every corner, and every patient gets CT'd, even if they've just got a flu. Unfortunately, those of us working in rural, semi-rural areas may not have those luxuries. But again, thank you so much for joining. And if you need to go back and have a look at it, it will be up on YouTube within the next few minutes. So please feel free to go back and have a look at that. It will be on the latest Insights playlist, and I'll put it on the radiology playlist as well. But if that's all, I want to thank everybody. And yeah, let me just start this here. And I hope all of you have a great evening ahead, and that each of you, will join us next time as well. Zoom is telling me we are about to cut out. There's just about a minute left. So I really appreciate, and thanks, I really appreciate all of you who have attended and who've contributed on the chat as well. All right, keep well and enjoy the rest of your evening. Bye.